We are going to talk about cardiovascular alterations part 1, vascular problems. So in this section, we're going to cover aortic aneurysm dissections, and peripheral arterial disease. As with anything else, there are chronic disease processes that can be managed as an outpatient versus the acute manifestations of these issues that require admission to the ICU area. So an aortic aneurysm is just a localized dilation of the arterial wall, which creates an alteration in the vessel shape and blood flow. So it's very common in older adults, and an abdominal aortic aneurysm is more common than a thoracic aneurysm. So when we talk about thoracic, we're talking about the portion of the aorta that comes off of the heart into your thoracic cavity in your chest. And then the abdominal one is talking about the aorta as it reaches in your abdominal cavity. So the etiology of aortic aneurysms is atherosclerosis, hypertension, blunt trauma, Marfan syndrome, and pregnancy. There are different types of aortic aneurysms. They call it fusiform and sacculated. And an aortic aneurysm doesn't always produce symptoms, nor is it always life-threatening concern. The concern arises for when it becomes a dissection. So an aortic aneurysm, in terms of management, they usually will determine based on size. So a thoracic aortic aneurysm is a CT surgery problem, and most often they will intervene on that. And an abdominal aortic aneurysm is a vascular surgery problem. So usually they try to manage them on an outpatient basis, monitor them for size changes, and determine whether or not that they need surgical intervention. So if it's less than 4 centimeters, could typically be managed on an outpatient basis, quit smoking, get good medical control of hypertension, also get the patients on a statin, control their plaque issues. Larger than 5 usually is a surgical repair or placement of an aortic stent to prevent the risk of rupture. So they want to also encourage weight loss, smoking cessation, and as I said, hypertension control. So what happens when a patient has a dissection? So this is a really cool imaging because this is from a real patient. It kind of shows you the area where the patient, when you have a dissection, the aorta less vessel walls will separate. So your arteries have 3 layers and those will separate. So you can have a dissection and that becomes the emergency of the aneurysm, if that makes sense. So both disease states, both the aneurysm and the dissection, are the result of progressive atherosclerotic disease, cigarette smoking, and systemic arterial hypertension. So these again are cardiovascular patients. So then we go here, how do I know that my patient has an aortic dissection, or what do I need to be concerned about when I'm monitoring my patients? An aortic dissection usually is identified emergently because these patients will have acute pain, severe pain, an extreme drop in blood pressure, and signs of shock. They're going to describe the pain as tearing. So when you hear somebody describe their chest pain or their abdominal pain as tearing, and they have any of those risk factors, hypertension, smoking, they're overweight, etc., then you need to be thinking about the possibility of an aortic dissection. So how does a dissection occur from the aneurysm? There's a tear in the lining of the main artery. Blood is going to rush through the tear, causing the inner and middle layers to split, and they call that a dissection. And if the blood goes through the outside aortic wall, if it basically ruptures all the way through, they're typically dead. Otherwise, if it's just kind of creates this false lumen where the blood separates and then it, enters back in, then usually there's something that we can do to help these patients. Now, they are classified according to the site of the tear, and we'll talk about the systems. They use two classification systems in clinical practice for the letters A and B, numerals 1, 2, or 3. They are called the DeBakey type 1, 2, or 3, or the Stanford type A or B. So a lot of patients with the type B or 3 dissections have hypertension on initial presentation, and typically we want to control their hypertension and see if some of that can be reabsorbed or well controlled. Patients with type A or type 1 and 2 present with hypertension, but they're emergent or urgent surgical candidates, as you can see, if that's where their dissection is. Anything typically in the ascending aorta and to the aortic arch is typically a surgical candidate, because if that ruptures, it's typically life-threatening. So also higher surgical mortality is found in patients who present with shock, hypotension, and poor organ perfusion, which should make sense now after we've had our shock and MODS lectures. Now, these patients, we talked about it, is the sudden onset of intense, severe tearing pain, which may be in the chest, abdomen, or back. So whenever you hear an acute tearing pain, you need to automatically think, oh no, is this patient at risk for an aortic dissection? The other cardiovascular warning signs, they may have severe hypertension, fleeting peripheral pulses, limb ischemia, or a new murmur that may indicate aortic regurg. And as the tear dissects or extends, because just because there's one little tear, it can keep getting bigger and bigger and bigger, the pain can radiate downwards as following the progression of the tear. So the most frequent acute neurological changes include altered mental status and coma. And again, as I said, we want to profile these patients so we know what to look out for when people are complaining of this tearing pain. So if the patient's stable, and as I said, it depends on the classification site, where it is in the thoracic aorta versus the abdominal aorta, the size, surgical candidacy. As a nurse, you don't have to determine that, but you need to recognize and respond to the tearing pain, to the hemodynamic instability, to the excessive hypertension. So if the patient is stable, they'll try to control the hypertension and for corrective surgery before it's more than 5, but that is their choice, the vascular surgeons or the CT surgeons. If the patient is seen with an acute aortic dissection, then typically we're going to try to immediately control hypertension with IV medication and pain with opioids. If the progression of the dissection can be indicated by their change in pain, so we want to frequently evaluate and assess for pain. Surgery is usually required for those dissections that involve the ascending aorta to prevent death from cardiac tamponade or sudden rupture or rupturing all the way through. Now, the surgical procedures include resection, graft placement, and restoration of the blood flow to major branches of the aorta. Typically, the aortic valve will be replaced too if the dissection involves area of the valve. The areas that involve the descending aorta do not always require surgery, even if they dissect. So that'll depend partly on patient stability, size, risk factor management, etc. As I said before, vascular surgery, the abdominal aortic dissection is a vascular surgery problem. They could consider medical management. You can see back here, they can do a covered stent, a synthetic graft, which they do an open repair, endovascular repair with stent, but they want to ultimately control hypertension and address the underlying risk factors. So your typical patients that get these aortic dissections are, we talked about for the abdominal aortic dissection, smokers, typically white male, a lot of times construction workers in their 5th or 6th decade of life. So that's who you're going to profile, along with an extensive cardiac history. So hypertension, plaque buildup, etc. So nursing management for these patients, we're going to still do hourly vital signs because this dissections are acute, life-threatening issues that can become acute life-threatening issues. So we're going to monitor the blood pressure in both arms. We want to check peripheral pulses, auscultate for an aortic murmur, EKG to detect ischemic changes or dysrhythmias. The acute tearing pain is that classic sign of an aortic dissection. We also want to evaluate neurovascular status, so that's neuro checks plus pulse checks hourly. We also have to document the presence and distribution of your pain, pallor, paresthesia, paralysis, and movement of the limbs. The medical management on this presentation includes an arterial line so that we can titrate the continuous blood pressure. We'll use labetalol to reduce cardiac output and lower the BP. We'll use peripheral alpha blocking activity to vasodilate the arteries and decrease the blood pressure. We'll use clofidipine, which is a calcium channel blocker, for rapid control of blood pressure. Typically, these patients will be maxed out on vasodilators to control the blood pressure, and it'll still be tough to get it under control. So we have alpha adrenergic blockers will give you moderate dilation of artery and veins. Labetalol, so we'll have potent arterial dilators with no effect on preload. That's nicardipine, clofidipine. Those are calcium channel blockers. We'll also use smooth muscle relaxants that can act as potent arterial dilators and moderate venous dilators. So that's nipride. But we have to monitor those patients for thyanocyte toxicity. And sometimes they'll have the blue urine as well. Now we're going to discuss peripheral vascular disease or peripheral arterial disease. The risk factors are the same for patients that have coronary artery disease, so patients that are smoking, they have hypertension, they have high cholesterol. Likely if you have atherosclerotic changes anywhere in your body, because it can occur in any artery, you have them in your heart and or other places in your body. So when does peripheral arterial disease become limb-threatening? That's what we're going to talk about. So basically, the patho of peripheral arterial disease is related to a spasm, inflammation, trauma, compression, thrombus or embolus formation, or atherosclerosis. That is not rolling off my tongue easy today. I apologize. How do I know a patient has a peripheral arterial disease that's concerning? One thing I do want to say is venous stasis is never really a problem. Sometimes they'll get a cellulitis from venous stasis, but it's really never an acute condition that requires hospitalization on its own. But peripheral arterial disease can be limb-threatening. And I'm saying limb-threatening on purpose because we are going to monitor these patients for ischemic limbs, essentially. So you've probably heard before about intermittent claudication. Lack of blood flow to distal extremities will produce ischemic muscle pain. This is usually the early stages of PAD. I also like to call this limb angina, or I would call this stable limb angina, because the pain is more intense with activity and goes away with rest. Okay? We know that PAD is getting worse when you have continuous burning or pain of the lower leg and feet, and it's actually aggravated after reclining or elevating the limb. And we can have a loss of limb when they have arterial blood supply cut off or occluded. So that would require immediate catheter or surgical intervention to save the patient's limb. So how would I know that my patient with peripheral arterial disease has an acute occlusion from the thrombus? We would have a change in pain, loss of pulses, pallor, coldness, motor sensory alterations, and this is ischemic pain. This is excruciating pain for patients, and we need to assess the limb. So if I'm no longer getting pulses, if the skin is cold, there's been a change, and they are complaining of ischemic limb pain, then we need an intervention to basically open the artery. So we are able to stent coronary arteries and open coronary arteries and do all sorts of bypass things. We can do the same thing with arteries of the limbs. So we can do stents, we can do bypass procedures, and we can do all of those things in order to save the tissue and save the limb. Now, it's common for these patients with chronic peripheral arterial disease to have atrophic tissue changes. Then they get the wasting of muscle or soft tissue because of decreased blood flow. And as it progresses, they can get ulceration or gangrene. Some of these patients anyway require amputation because they can't get adequate blood flow to the limb. That is a different situation than the acute ischemic pain of peripheral arterial disease. Now, one way vascular surgery asks nurses to monitor the progression of peripheral arterial disease is to do an ankle brachial index. So oftentimes they're going to ask you to take an ankle blood pressure and a brachial or an arm blood pressure, and you're going to divide it and measure it in the leg. And then you're going to divide that number and you're going to get this index, and you will be tested on this. The index is going to let you know the severity of the PAD or decrease in flow based on those blood pressure numbers. So you'll be asked to do this as a nurse, and you'll need to know what the significance is, and they'll ask you to notify them. And typically when it's moderate to severe, these patients need some type of intervention. So what can we do for peripheral arterial disease? Well, we want to address the risk factors, but that takes time. These patients need to be put on anticoagulants, vasodilators, antiplatelet agents long term. We can actually do a PCI or a opening with a stent placement to open the artery, or we can do a bypass to remove the occlusion to restore blood flow. So it's the same as what we can do for revascularization for any other artery. We can do a bypass, we can do a stent, we can give medications to open it up, and so forth. Now, what is your job as a nurse, especially for these patients? We're talking about peripheral arterial disease. We need to monitor their pulses, right? You'll see patients that are getting hourly pulse checks and neurovascular checks. We also want to prevent skin breakdown and injury. They have issues with sensation. We want to monitor those ulcerations and the gangrene or other signs or symptoms of infection. These patients need good pain control because this is ischemic limb-threatening pain. We need to give the patient and family education about what we're doing. We also need to, after they have an angioplasty, which is a balloon, or they have a stent, they are still at risk for the same things that they would be from a cardiac procedure. They're at risk for dysrhythmias, renal failure, hematomas, because anytime they're accessing arterial sites or doing arterial bypass procedures, you may have heard of like a fem popliteal bypass or other types of vascular bypass surgeries, you're still at risk for those same things. Patients are at risk for bleeding. You want to check the site for hematoma. You want to check for distal and proximal decreased perfusion or other issues related to that. So that's something that's well within your scope. Another situation that you guys have heard about prior to now is a venous thromboembolism. So we can have this as in our venous system now. We can have a DVT, which is a deep vein thrombosis, or we can have that migrate and become a PE. Now in any vein, this could potentially happen, but this is considered a clot or thrombus that forms in a large vein in the leg, pelvis, or arm. Patients are going to have inflammation, pain, tenderness, redness, and swelling at the site. You'll take care of patients that may have unilateral swelling on their arm or their leg. The danger of a DVT is that the thrombus can migrate through venous circulation to the pulmonary vascular bed, causing a pulmonary embolus. And so that's one of the dangers there. And in order for patients to develop a DVT, we have something called a Virchow's triad. So you need 2 of the 3 of these criteria to develop a DVT. You're typically going to have 3 predisposing factors to a DVT. You have to have some type of stasis of blood, endothelial injury, and hypercoagulability state in order for this kind of perfect storm to occur. We diagnose this on ultrasound. A D-dimer is not as helpful. It just tells you that there are clots. It doesn't tell you where. So really the ultrasound is our gold standard to identify where. And assessment-wise, you're going to have a swollen extremity that's warm to the touch, that will be tender, that the patient will complain about. Oftentimes, that's why they'll seek care if they're coming in from an outpatient setting. If they're already in the ICU and they're intubated, sedated, this is where your nursing assessments come into play of really good physical exam. If they can't tell you and you notice that the nurse before you didn't mention unilateral swelling and you feel warmth at the site, then you want to be cautious and get that evaluated. So unfortunately, most of our ICU patients' symptoms are masked. So that's where you have to say most our ICU patients are great candidates for Virchow's triad, and they're predisposed to developing that, hence why we put everybody on SCDs and sub-Q heparin. This is all to prevent this from happening. A lot of people's DVTs are asymptomatic. They just may have the swelling, and then they could have a positive Hohmann sign, pain and calf on dorsiflexion. But if you're suspecting a DVT in the ICU setting, we do not dorsiflex their calf because that could cause it to migrate potentially. Once you have a patient with a confirmed DVT, they're on anticoagulation, typically IV heparin. If there's no other indication for the anticoagulation, sub-Q heparin or Levinox is fine. A lot of times they'll be on oral antiplatelet therapy as well. And we have to monitor them for signs and symptoms of a pulmonary embolism, which will be chest pain, dyspnea, hemoptysis, tachypnea. They also could suddenly go into aflutter or AFib. That could be a sign of a PE, so those patients need to be evaluated for that as well. And a pulmonary embolism, as I've kind of said, is a complication from a DVT. The thrombus can migrate as a VTE, a venous thromboembolism, through your venous circulation to the pulmonary vascular bed, causing the pulmonary embolus as an obstruction. And the signs and symptoms are chest pain, sudden shortness of breath, altered level of consciousness. Now, it may not be an obstructing PE. We have something called the PERT team at Loma Linda. It's actually pulmonary doctors and MICU physicians that are on a pulmonary embolism response team, the PERT team, and they decide if a patient's a good candidate for IR, for thrombus removal. So if a PE is suspected, we're going to do a chest CT angio to detect emboli. And we could do a VQ scan, but that's not really helpful in critically ill patients, and it's a little more troublesome to get a good VQ scan. The PEs can be fatal, so patients can get catheter aspiration or thrombolytics for that if they are a good candidate, and if they're not already, they will consider intubating them. Questions, post them on the discussion board. We'll go over a few of these high points in lecture, and I hope you enjoy learning about vascular alterations.